afternoon. Thank you for joining us this evening. My name is Maria. We're with Equal Hope. This is Paris Thomas. Hi, Paris. How are you?
Hi, MJ. Thank you for having me.
Thank you, and thank you everybody for being here on Black History Month. Paris Thomas is our Director of Programs and Operations for Equal Hope. She's been with us for 3 years. She is a PhD candidate for Northern Illinois University. Since this is Black History Month, we're going to be talking about the equity that involves the Black community. So, Paris, what is health equity and why is it important?
Yes, so health equity is basically when every person has the opportunity to achieve their full health regardless of their social position or any determinants of health. Health equity is important because it really dictates how a person is able to achieve quality care. If you have health equity, then everyone is accessing the system and having equal health outcomes. Unfortunately, today we are in a system where health equity is something that we're still battling and still trying to achieve, as there are still disparities that plague many Black and brown individuals.
Absolutely. And before we get into the meat of health equity, I just want to make sure that we understand the difference between health equity and health equality. What would be the difference between those two things?
Yes, so that's a really great question. When you say health equality, that is basically where everyone is giving the same exact resources. So if you look at Chicago's landscape, we have so many great hospitals here. We have equality. Anybody can technically access these facilities. Equity is where you consider a person's actual circumstance and you allocate those resources appropriately depending on the person's circumstance. So then once again, when you look at our health system, some of our facilities are located in positions adjacent to communities, underserved communities or communities of lower income. So all of our resources aren't allocated appropriately, meaning that we don't have health equity. Equality, same. Equity means that we're allocating appropriately based on people's circumstance.
Absolutely. Absolutely. It's addressing those needs of those people who need it the most, right? How has historical racism in Chicago created or influenced health disparities in Black communities on the south and west sides of Chicago?
So that is a loaded question. Right now in Chicago, there's about a 30-year life gap between Black Chicagoans and white Chicagoans. So there is a disparity here when you talk about historical injustice or historical racism. And it goes back to not just like a system problem, but even when you talk about medical mistrust. So when we go back and we think of studies like the Tuskegee study of syphilis, where a Black man with syphilis were withheld, from treatment and went around and basically caused a lot of Black men to either have long-term illnesses such as blindness or have early death. Or we talk about Henrietta Lacks, where, her cancer cells, she was a cervical cancer patient at Johns Hopkins Hospital, where her cells were actually used without her consent to basically, be utilized for other treatments, where they weren't utilizing people, but they wanted to test other things. So her cells were these immortal cells. So when you have cancer cells, typically they die. Her cancer cells were multiplying at numerous fast rates. And so that's an issue because it is causing a mistrust in the Black community. Specifically, even her cells, which are called HeLa cells, are then spread and then are used in vaccines like the polio vaccine and even the COVID-19 vaccine. Her family has not profited from this, but yet the medical community technically has profited from this. So this causes a mistrust in Black communities. And then when you talk about structural systems that are set up here in Chicago, you think about even back in like the 1870s, as many people migrated from the south to the north, and many Chicagoans settled within what was known as the Black Belt of Chicago, which was basically where Black Chicagoans were able to access things and were all living in a certain line between certain streets. So within that, you have Chicagoans that come here to Chicago looking for opportunities and things like that, but then those opportunities aren't always granted to them. So in Chicago's structural racism, we have things such as our projects that were created, like the Robert Taylor Homes or the Cabrini Greens, the Rockwell Gardens. All of those facilities were created and basically put in place because of policies that wanted to keep Black people in a certain facility. And so the main reason those facilities were created is because Chicago wanted to keep Black people in the smallest capacity and smallest space in one area. So they built these huge high-rise towers projects that they said would help individuals, but instead it was probably one of the worst housing disasters in American history. So individuals here are looking for housing, and then they have other things such as like redlining. They're not able to obtain mortgages or housing, and they're kept out of white neighborhoods. And so everyone is being pushed in certain directions here in Chicago. But within that, there are, flaws within the system of housing. So when you think of like the Cabrini Green and the Rockville Gardens, those facilities were these huge towers that were hard to maintain and were infested and had numerous, things happening, such as violence, and there was disease, and people couldn't access things they needed to in those facilities, and they were, resource restricting. And that was done on purpose. Mm-hmm. And then even so, when, Chicago finally realized, and the Chicago Housing Authority finally realized, like, this was a bad decision, maybe we shouldn't have did this, and they decided to tear it down because of all the violence and all the displacement for people, they displaced all of those families who had called that home for such a long time. And when they did that, they did so with the promise that one day those individuals would be able to come back and have a house or be able to live in those environments again. But instead, they were pushed out into, like, the south suburbs or the west suburbs, and that model continues to happen with gentrification. So you're pushing people away from a city full of resources and pushing them out where they're encountering more barriers, such as like transportation, food deserts. They don't have all of these things, causing the disparity eventually that it relates to health. So these individuals are, and problems aren't just one-sided, I think, but when you look at, I think, the housing structure of Chicago, it really does relate to some of our health disparities and some of our policies that are in place. Even environmental policies, such as our huge highways. Chicago is a huge highway. You can access a highway everywhere, 290, 55, everywhere. You can get on the highway. The problem here is that when those highways were built, there were policies put in place to build those highways through communities that were underserved or deserted or lower poverty. Mm-hmm. The problem with this is that you have gas fumes, pollution, things like that, causing the kids in those neighborhoods and to have higher asthma rates and things like that. So all of these policies that are systematic caused health disparities that probably weren't intended, maybe intended. I can't say what was behind all of those thinkings, but it caused health disparities that have then plagued many Chicagoans today. And you still see that in like the gap of life between Black and white Americans. And I think it's very interesting, especially for our organization, as we look at other cities like ourselves. Chicago is one of the most racially diverse and dynamic type city you can find, but one of the most segregated cities here in America. And when we compare ourselves to cities like New York or San Francisco or Philadelphia, these neighborhoods don't have the same health disparities that Chicago has. Mm-hmm. And I think it really relates to our institutional policies, our policies around housing, our policies around transportation, our policies around environmental, components is really what contributes to those health disparities and what makes it different. At one point, when you look at like Cabrini Greens or the Rockville Gardens, when they did kind of an American analysis of all of those facilities, those entities had the lowest poverty rate out of all cities with projects. And that speaks, I think, volume for Chicago. Yeah. And even so that, still today, we're still a very segregated community. You can come to Chicago and be like, I can run into so many diverse people here. Mm-hmm. But then you're like, well, why is everybody grouped off in these different, components throughout the city? And it's done so in a purposeful manner. Yeah. So I move you south, I move you to the south suburbs, I move you west, I move you to the west suburbs. I know that those entities aren't as resource dense as in the city. Mm-hmm. And it continues as, gentrification continues to move forward. As people are moving into new communities, I think we see those changes even in the west side as people are moving and like, we want to be closer to, the United Center. Yeah. And they're moving people out so that they can build more resources that they didn't build in the first place for those people in those communities. Mm-hmm. And specifically, Black and brown people, unfortunately, are suffering, the impact of those things.
Absolutely. So it seems like it's an all-encompassing, multi-generational, systemic problem for the Black community.
Absolutely.
What are some of the social and economic factors that contribute to health disparities among the population on the south and west side? Like you mentioned, the highways. Mm-hmm.
So I think when you talk about the social and economic factors, there's multiple factors, and you can probably do a whole list. We could be here all day. But those include things such as employment. Yeah. Employment is probably the number one thing that I'm going to always advocate for, because you need employment to progress, and you need equal employment and equal income in order for individuals to progress and be able to move to communities where they have those resources. And then there's things such as education. Employment and education are tied in together. You have to have a quality education in order to access that employment. And when we go back and we think about, when the projects were set up, or the communities today that are Black and brown, some of our our family members, our friends, just Chicagoans right now aren't accessing the best quality education that they could afford. They have lower resource schools, the funding isn't going to those schools, and so that is still creating basically a poverty circle to continue that cycle of poverty. And then you have things such as like housing, as we spoke about, or transportation. There's a transportation desert in the south suburbs. Like, we have great transportation here in Chicago. You'd be like, oh, I can get anywhere. I can get on the train. I can get on the L. I can do all these other things. But eventually that transportation runs out, and it does become a gap there. You have things such as safety. I think when we talk about health and social and economic factors that are impacting safety here in Chicago is like one of the number one things. As you can imagine, when you aren't safe, you have a stress response that is basically creating other unequal disparities throughout your other health outcomes. If you're constantly worried about safety, or you're worried about your grandson, or you're worried about, all these other things that are happening, you are constantly in a state of stress, and you're kind of living through post-traumatic stress disorder yourself, which is usually related to people when they go away to war. And so that's really interesting, because we're seeing outcomes specifically in physical health outcomes that are related to those in violence. So people that are impacting and experiencing violence and living in these high, crime rate communities are having, lower death rates, dying at 60 when, other individuals die at 80. There's so many gaps there when you think about that. I think other resources or factors that are contributing is also food security, the language issues, medical bills, health coverage, and the quality of care that people are accessing. So here in Chicago, we have these great facilities. You can name 1,000. University of Chicago, Northwestern, Rush, all these amazing facilities, but at the same time, we have safety net hospitals as well. And I love the idea of safety net hospitals, but they were created from the government to basically be an entity that could serve the neighborhood where they're at. The problem with safety net hospitals is that they're always not providing the quality type of care you would get at the University of Chicago or Rush. And sometimes it's creating stagnant care or gaps in care versus having comprehensive care when you go to these other facilities. But I also understand why our communities utilize these safety net hospitals, because they're safe. If I can walk in and I know my best friend is like, she's at the register, my friend works here, these people make you feel safe. It's surrounded with people that look like you, that think like you feel safe in these environments. And sometimes when you get into these big academic institutions, you feel lost in the system, and you're kind of like, well, this is really big. People don't understand me. They look at me funny. And so I can understand why people utilize them, but it's also causing a barrier in our care, because sometimes they aren't able to get the quality care that you would get at these other facilities, or draw in the physician quality that these other facilities would draw in.
So it's more than just social and economic factors. It's like a problem that has been instilled not only by our parents or like our structural problems. These are things that have occurred to people individually. There's certain experiences that people feel that they don't feel comfortable coming to these different huge hospitals that they usually feel comfortable coming to. But what are some current structural barriers that continue to increase health disparities in minority communities?
Yeah, so I think current practices today that are still structural barriers contributing to this include discriminatory practices, specifically those that contribute to people accessing care or getting the assurance of equal treatment that they deserve. When we say access to care, it's being able to access those quality facilities. So sure, like we talked about, we have equity and then you have equality. We have equality, sure. We have all these great facilities. Anybody can access them, I guess.
Yeah.
But we don't have equity, and the problem here is that many individuals don't have the same insurance types. They may be on Medicaid. They may be restricted to the physicians they're supposed to see. They may be restricted to the hospital setting they're supposed to be in, and they're not able to access the quality care that they deserve. Even so, when they're accessing sometimes that quality care, they're not getting the quality care they deserve based on provider treatment. Sometimes a lot of Black and brown individuals are receiving treatment that's less par than those of a different racial background. And that's made up of myths that sometimes are taught in the medical system specifically. So I know there was research back in the day that showed that Black people had basically a high pain tolerance. Mm-hmm. So we could withstand pain, and we didn't need the same medications that everyone. And that was a myth that carried on today. Yeah. Like, people still think it in pregnancy. It's shown like that they think that the pain level is different for Black people than it is white people, which is not true.
It's not true. Mm-hmm.
And I don't know why these misconceptions continue on today, but it's still being practiced and thought. And so it really is tearing down the fabrics of kind of those structural barriers that continue to increase health disparities in minorities. Then you have things such as like quality of care. So not only just accessing the care, but the quality type of care you're receiving. So I think, for example, when you use cancer or mammography specifically, we have these accredited radiologists that, you know, are sit into cancer centers, but not every facility has that. There's certain training that radiologists receive to become accredited specifically for mammography. Certain people don't receive those trainings, and what we found in the past, specifically through our research, is that people's cancers were being missed because people weren't taught properly how to find that. And so people could be walking around for 10 plus years, specifically Black women, without a cancer being detected, which eventually will metastasize or lead to triple negative breast cancer. So these are things that, you know, we're out here trying to fight for those structural barriers that are contributing to those health disparities.
Yeah, and that's the disparity that you're talking about, just women being able to walk around with their cancer sitting there just for years just because someone decided to, or someone missed and didn't have the proper training. Those are the kind of inequities that we're talking about. On a little bit more of a positive light, which is kind of hard given the fact that this is something that is very real and this is something that is happening to everyone, especially in the Black community, on a daily basis. But what are some strategies what strategies currently exist to promote health equity in the Black community?
So two of the biggest strategies that are being utilized today are first community health workers. I am an advocate for community health workers. I think it is the best thing that any of us could have ever done in this space, and I'll tell you why. Because we have providers, we have nurses, we have all these people who don't sometimes always reflect or relate to the community they're serving. Community health workers is a great intervention point because it is people hiring individuals from the community to be that advocate for the community and that link to care. Community health workers can go out and talk to the community. You can talk and feel safe in that environment. And we can talk about mammograms, or we can talk about COVID, or we can talk about all these other things. And I don't feel like I'm being judged if I tell you, hey, I don't want to get the COVID-19 vaccine, because those community health workers are supposed to be a safe space and help you access your resources and then also help you learn the system a little bit better. They're providing education, they're doing outreach, they're canvassing in these communities, and they're connecting people who are traditionally disconnected from healthcare to healthcare. And so I think that's one of the greatest things. There's a push right now for community health workers. There's legislation around it for reimbursement around community health workers. Equal Hope is an advocate for community health workers. I just can't stress it enough. I love community health workers. And then there's cultural competency. And so one of the interventions that I truly think that needs to take place is really cultural competency training, not just for providers, but for all people within the healthcare institution. I think we really need to help providers understand the people that they're serving so that they don't have any distrust or disdain or myths that are blocking them from providing this best care. So that's a really, really important thing. Another thing, just from my own perspective and from my own research, is that we also have to invest into the communities that we're serving. So we have so many providers, and specifically there'll be a provider shortage happening within the next couple of years as many providers are retiring. Many people aren't going into the medical field, or it's really difficult, as you can imagine, to be a doctor, but specifically, there aren't a lot of Black physicians. There aren't a lot of Hispanic physicians. We need that. And so we need to invest in these communities that we serve that, you know, kind of benefit from Black and brown communities, and make sure that our children are getting the quality education that they deserve, are being exposed to these things earlier in life so that they can get a leg up, and then providing a financial backing so that they can really be pushed through the system. Absolutely. To really become a provider, to help kind of address these gaps and really provide more cultural competent care. Because it's one thing to serve a community, and I love doctors, don't get me wrong, this is not against doctors, but it's one thing to be a doctor of another race and serving an individual who's Black and brown and underserved community. You make a 6-figure salary, if not more, and this individual is struggling just to eat. And so there's a disconnection here between the two. And so we really have to address this disconnection so that they don't come in with myths or misconceptions when providing care to this individual, and don't just treat them like a number, but as an individual who needs that equity, not equality.
Oh, look at you.
Look at that.
So we have culture diversity, we have community health workers, hi, and we also have investment in these communities for the future.
Yes.
How can policymakers and healthcare providers improve at addressing health disparities and developing effective strategies and health equity?
Yeah, so that's good, and I feel like I talked about some of that before. I think the first thing for providers, like I said, is dispelling those myths that exist right now. Having that financial backing for communities and for having people of color in those spaces. The other thing is for policymakers to hold each other accountable and specifically remove those racist practices that have been in place all this whole time. Discriminatory practices that surround housing, mortgage access and educational gaps, and invest in communities of color. And I'm sorry, I have to cough. I'm sorry, and specifically close that wealth gap.
Yeah.
In order to close that wealth gap, we can really make a change here. And not just invest, but invest in the people. Because I think it's easy for everybody to say, we're invested in the West Side or we're invested in the South Side. Well, how invested are you?
Is that equity investment?
Yeah, it's the equity investment. And I tell people, I think a lot of organizations and businesses are really right now invested into Black and brown communities, specifically after George Floyd. And kind of you see everyone's like Black History Month. And, Target has made a change. Bath & Body Works is selling candles that are Black History candles. It's a lot. But the thing is, you really have to change the dynamic of your organization. You can say you serve people from the West and South Side all the time. What does your board look like? What does your leadership look like? What does your staff look like? Do they reflect the community you serve? And if they don't, I don't feel that you're 100% invested into these communities.
Absolutely. We were looking at something last night, and it talks about how someone who is from a different culture cannot fully understand the obstacles that someone from a specific culture has. So you're right about making sure that we're culturally reflective, including in our board. How have different policies increased or decreased health disparities in the South Side? Can you give us some good news? Give us some bad news?
So good news is I think there's a lot of entities making movement around this.
Okay.
Pushing policies forward, but I can't talk about the policies that really have contributed to those disparities on the South Side, such as the zoning laws. We talked about where people live and kind of redlining and pushing people to this one area where there are no resources. Then you have things such as gentrification and the public housing and community violence. I think we still have a long way to go, I think, with policy. But specifically, there are organizations out there doing amazing things to really combat a lot of these things that are happening. And I'm not a policy expert, so I can give you a rundown. We have a policy person on Equal Hope. But there are things in place to help these individuals, and I think it's going to take some time to undo a lot of these things that have been put in place. Like when you think about, the 1994 crime bill or the 3 strikes policy or the war on drugs. All these things were put into motion a long time ago, and it will take a while for us to unset what has been set in place.
Absolutely. It's going to take a while to reverse years and years of systemic racism that has affected the Black and brown community for years,
Yes.
in every aspect, whether it has to do health, food, housing, those are things that encompass the person as a whole. So another question, what is a community engagement and critical component of promoting health equity?
I love that question. So something that's really critical to promoting health equity, in my opinion, is community voice and community buy-in. Any intervention that is looking to kind of, engage the community has to have community buy-in. So you have to have the community voice, and you have to let the community know that you're there for them. So things such as focus groups or involving the community in your leadership board, involving the community in stakeholders and community, tables, so that they can tell you and build that trust. Because I think a lot of people come in with, hey, I have a solution, I have this idea for this organization, I'm going to create it because I want to, I saw the data, I want to fight this disparity. But you're fighting this disparity without seeing the whole picture. And so it really takes those individuals to sit down at this table and get them involved in those things so that they can tell you what the real issue is. So you can come in and assume I assume transportation is the issue why people don't access all of the care they should or access quality care. I could be 100% wrong, and most times people are. There's so many other things that are affecting people, especially when you have the social determinants of health that really keep people away from these things. Yeah. I'm worried about my housing. I'm worried about keeping my lights on. I have kids to feed. I don't have time to go to that appointment. I have transportation. I just don't have time to go. I work a full schedule. There are other things that we don't consider, and you have to really get the community engaged in order to put an intervention in place that will actually make a change.
So without the community voice, you can be as good intentioned as you can be, but you need to make sure that you engage those people in the community.
Absolutely.
So what are some types of programs that Equal Hope and Rush implemented to address health equity?
So Equal Hope is one, yes. So Equal Hope is a great program that, was implemented to fight the disparity in breast cancer in Black women and white women here in Chicago. In 2008, there was studies showing that Black women here in Chicago were dying at a 62% higher mortality rate than white women here in Chicago. Equal Hope was put in place to reduce that disparity, doing so through quality projects, doing so through policy and advocacy, and doing so through outreach, education, and navigation. Another project that Rush has put on the table would be Westside United, which is another partner of Equal Hope's that we work closely with that is working to fight disparities on the West Side. Health disparities projects like Equal Hope or West United are great entities to be put in place because they're driven from a community voice. They're driven from data as well, but from a community voice and really involve community stakeholders at the helm. And so you need these things in place in order to really fight those disparities and have, those results that you're looking for. Mm-hmm. Health disparities aren't going to be cured overnight. Health equity isn't going to change tomorrow. We have to rewrite a lot of wrongs that have been put in place, and it's going to take a lot of time. It's going to take a lot of policies, a lot of government buy-in, but if we want to make a change, it can. And it seems like everyone seems like they're trying to move forward. So hopefully in the future we can see those things progress and see those death rates drop specifically for Black and brown individuals.
Absolutely. And Equal Hope is one of those entities where you can definitely come and we'll help you navigate you through the system. And we see you as a whole person. We believe in that health disparities are some things that affect people in the Black and brown community as a whole. If you would like, we have here our Equal Hope website. If you have any questions, comments, or concerns, you can see our different focus areas right up here and our services right here. If you need to contact us, our number is right up here. And here are our staff. Here's our Donna Lynn and community health workers. But if you have any questions, comments, or concerns, or would like to sign up for services, mind you, our services are free. Please give us a call at 312-942-3368. Thank you so much.